Hello everybody, my name is Robert McCabe and I'm a fourth-year neurosurgery resident at Ascension Providence Hospital in Southfield, Michigan. I will be discussing intravenous tranexamic acid and perioperative blood loss in minimally invasive 3-level lumbar fusion, a feasibility study. The authors declare no conflict of interest in this presentation. Tranexamic acid, or TXA, has been shown to effectively reduce blood loss in open lumbar fusion. However, intravenous TXA has not been studied in minimally invasive transforaminal lumbar interbody fusion. I will refer to MITLIF as minimally invasive lumbar fusion from here forward. Surgical complications, including blood loss, has been shown to be positively correlated with increasing levels of lumbar fusion, with some studies citing similar complication rates with minimally invasive or open approaches with 3 levels or greater. Effectiveness of IV TXA in multi-level MITLIF is currently lacking. Objectives for this study include assessing the feasibility, safety, and efficacy of the use of IV TXA in 3-level minimally invasive lumbar fusion, as well as utilization of these results for implementation of an IV TXA quality improvement project. The study methodology was derived using PCOS, with P for population, I for intervention, C for comparators, O outcomes, and S for study design. The population were patients from a single institution with multiple surgeons in a consecutive series from August of 2017 to June of 2019. Eligibility included all adult patients who underwent 3-level minimally invasive lumbar fusion. Patients were excluded that were less than 18 years old, had a concomitant surgery, or were currently enrolled in another study in the same hospitalization. Intervention was the use of IV TXA immediately before skin incision in either dosing of 1 gram IV in a 100 milligram per minute infusion or a weight-based dose using 10 milligrams per kilogram IV in a 100 milligram per minute infusion. Comparators were the IV TXA group versus control group who did not receive IV TXA. Outcomes included feasibility, safety, and efficacy of the use of IV TXA. The study design was a feasibility study, specifically an observational comparative cohort. Outcomes included feasibility using perioperative blood loss in the non-TXA group to establish a baseline blood loss for 3-level minimally invasive lumbar fusion. Safety was determined using the incidence of venous thromboembolism between the two groups. Efficacy was the perioperative blood loss between the groups, and secondary outcomes included length of stay and operative time between the groups. 30 eligible patients were included in this study, and as you can see in the patient demographics, there were no statistically significant differences regarding for age, sex, BMI, smoking history, and preoperative anticoagulant use between the TXA and control groups. We found that the drop in postoperative hemoglobin was statistically significantly reduced in patients receiving IV TXA. Additionally, we found that the drop in postoperative hematocrit was significantly reduced in patients receiving IV TXA. There were no adverse events, either pulmonary embolism or deep vein thrombosis, in any patients who received IV TXA. As seen in the prior slide, this table demonstrates our statistical significance in postoperative drop in hemoglobin and hematocrit in the group receiving IV TXA. Estimated blood loss, units transfused, hospital length of stay, operative time, and incidence of venous thromboembolism was not statistically different between the groups. In conclusion, IV TXA usage significantly reduced hemoglobin and hematocrit drop postoperatively. There was no increase in any thromboembolic event in patients who received IV TXA. The results of this feasibility study are currently being used in the design of a quality improvement project at our institution. Thank you.